and welcome everybody. It happens to be noon on a Thursday in March, and I think we are just tipping off March Madness, actually. We probably just had our first tip off for, hopefully everybody got their pools in. I think you just missed the deadline if you didn't get them in, but good luck to everybody on March Madness. So today we're going to talk about a little billing madness and talk about the No Surprises Act and its effect on strategy operations between providers and payers. And we've got an esteemed panel here today to walk you through some of the compliance aspects and some of the requirements promulgated by the No Surprises Act and some of the details. But we're also going to go well beyond the kind of the compliance lens and talk to you about operational challenges, but also operational opportunities. We actually have a point of view that there are quite a few opportunities on both the payer and the provider side that we're going to share with you today. Our panel is diverse and actually plentiful. We actually have four panelists here today, including myself, and happy to have all of them on board. Nick Rhodes, Kevin Coonan, Michelle Ray, and myself, David Gregory, are going to take you through this presentation. We're all going to, come at you with a couple of points of view. Kevin and Michelle are largely going to wear the payer hat in this conversation. Both of them have been in health plan operations for a decade or more. And Nick and I are going to take on, to some extent, the provider hat, although I think all four of us will probably, present a well-rounded view of this. But we do have payer experts and provider experts on this webinar to help you kind of sift through some of the key requirements of the No Surprises Act. So panel, welcome. Attendees, thanks for joining, here, and looking forward to imparting some knowledge for sure. And then panelists, I'll ask each of you to kind of just briefly introduce yourselves when your first slide comes up, if you don't mind. So why don't we talk about the learning objectives for today's webinar? So we're going to outline the various components of the NSA, and we're going to talk to you about evaluating the impact of it on revenue cycle, managed care, and information technology, et cetera. We're also going to look at the effect it'll have on out of network providers and the payers that are viewing those out of network claims, and looking at all the different processes that go into this, the QPAs and the dispute resolution framework and things of that nature. But as I said in my opening comments, the fourth learning objective there is to really kind of get out of a compliance mode, which is important, right? We will be talking about compliance with NSA, but also to talk about some of the opportunities that are beyond compliance. So looking forward to hitting these learning objectives. I will also say that the QA, I think there is, and I think the moderator did indicate that you have the ability to put questions into the chat, and we'll evaluate those and try to get to as many as we can, because I know we've got a fairly large group here today. So those are our learning objectives. So why don't we jump right into it then? I'm just going to take the next 2 or 3 kind of overview slides. And then I'm going to turn it over to Kevin to get us rolling from a panelist standpoint. So here's the overview. I'm not going to drain necessarily every bullet point on this slide, and I think we will share this deck with all registrants, after the webinar for sure. This was effective January of 22, just to kind of level set on that, and it really. I mean, at the end of the day, most of my career, surprise bills have just been part of the fabric of the healthcare ecosystem, right? And it's also been a very frustrating part of the fabric of the ecosystem. And this bill, at its core, is simply to eliminate or at least minimize the number of surprise bills that members get. So the idea is to increase member satisfaction. and other stakeholder satisfaction, and to streamline a process, and to at the end of the day, minimize the surprises that most of us on this call have probably experienced either ourselves or in our family for sure. So the other key points that I guess I'll mention here is the qualified items there in the middle of the slide, right? Emergency services, non-emergency items and services furnished by out-of-network providers in certain in-network healthcare facilities, right? So we're going to talk a lot today, and I think Kevin will probably drive this point home about out-of-network, right? And so what we really mean is to say that there is no contract, there is no paper between the provider and the payer, and that's when the No Surprises Act kicks in, right? So just a level set that out-of-network is also analogous to non-contracted, right? And oftentimes the surprises that we've all experienced are because there's a lack of a contract. So just a level set that's largely the focus of the No Surprises Act, and that's going to largely be the focus of our presentation here today. So it limits cost sharing to in-network deductibles and out-of-pocket maximums. You can see in the fourth bullet from the bottom. It applies to services payable by health plans in the group and individual markets and all self-insured plans, and it does not apply to services payable by Medicare, Medicaid, CHIP, or TRICARE, right? So those are some of the highlights of just the basic building blocks of the No Surprises Act. Some of the things that I didn't necessarily call out on these bullet points, I'm sure that our team will end up covering off on as we move through the presentation. But if we could go to the next slide, please. So we've got our first polling question. I think we're going to have 4 today, and that'll obviously allow for CPE credits. But the first polling question is, which of these services are not covered by the No Surprises Act? So you've got the 5 choices: air ambulance services, emergency services at an out-of-network facility, services from an out-of-network provider, in-network facility, ground ambulance services, or not applicable. We just give you that last option in case you're not necessarily a payer or a provider. As we understand it, it's largely a provider audience we're talking to today, but we do see quite a few health plans in the audience as well, and interested in both perspectives, and are certainly going to be presenting from both perspectives for sure. So that's our first polling question. It'll be open for approximately 90 seconds to 2 minutes, and we will share the results with you, at the before we present the next polling question. So next slide. So again, just to reemphasize, what I'm doing is just setting the table here for the rest of the panel to dig into the meat, right? But the services included are the emergency services provided at an out-of-network facility, air ambulance transport services, but not ground ambulance services. Hint, hint on the polling question. And non-emergency services provided by an out-of-network provider, even at an in-network facility, without the member knowingly electing that provider, right? Because the age-old issue of the surprise was that oftentimes providers are kind of imposed on members in given circumstances. A lot of, the best example is hospital-based providers like anesthesiologists, pathologists, ER physicians, right? Members don't have a choice in emergent and urgent situations, and even sometimes in elective situations when it comes to anesthesiology. And that's really the scenario that's kind of in the crosshairs here of the No Surprises Act, is trying to, as I said before, minimize and even try to eliminate the surprises coming from those scenarios. Next slide. So I'm going to, at this stage, I'm going to turn it over to Kevin Kuhn. And Kevin, if you want to just briefly introduce yourself, and then dive into one of these claim payment examples, that'd be great.
Sure. Thanks, David. Appreciate that. So I am a director in our healthcare consulting practice at Baker Tilly. I've spent most of my time working with health plans, payer clients on especially network reimbursement. And NSA impacts network reimbursement, right? It changes the payments to the providers a little bit, but also impacts how member share gets calculated. And we're going to talk a little about that in this webinar. So maybe to just talk a little about how does NSA work, a little bit about the mechanics. And there's lots of different scenarios that we could talk about. We picked a relatively simple one here. But so on the left, before NSA, let's say that a patient goes for emergency services, let's say, and the bill is $5,000. But that provider is out of network, and as David mentioned, in this case, what we're talking about in out of network is non-contracted. So there is no contract between that provider and the health plan. There's no underlying plan agreement. There's no network agreement. There's no hold harmless arrangement. And so those health plans typically, we'll talk a little about this later, but state by state rules will have some payment methodology. Each plan will have a payment methodology to pay those out of network providers or calculate the allowed amount to which the health plan believes they should pay for those services. And in this case, it's $1,500. The member co-insurance is based on that $1,500. But then the provider says, well, we billed you $5,000. We should be paid $5,000. And so a balance bill comes along to the member. There's no hold harmless arrangement because it's non-contracted provider. And the member is billed for the remaining $3,500 that the health plan plus co-insurance didn't cover. And so provider is made whole with their $5,000 payment. Payers paying $1,200, the members paying $3,800, their co-insurance plus the balance bill. And members are often surprised by this, right? This is member may not have chosen to go to that ER that was out of network or received the service that they did. So after NSA, the goal here from the federal government is to disallow, to ban that balance bill underneath this particular circumstance. So in this case, you have a $5,000 bill. The health plan says we're still going to pay $1,500. We calculate the allowed based on that health plan's non-contracted payment methodology. They calculate $1,500. But now something different happens with the member share. The member share is not based on the out-of-network payment anymore. It's based on something called a QPA, a qualified payment amount. And that QPA is supposed to represent in the median in-network rate. If that provider, let's say we're in network in that geographical area for that service, how much would the in-network rate be? And in this case, let's say, just for example purposes, it's $2,200. The member then pays their 20% co-insurance on $2,200, so they pay $440. So the insurance in the health plan pays $1,060. The member pays $440. The provider gets $1,500, but they can no longer, in this case, balance bill. So ultimate kind of reduction in payment for the provider, the member uses a different amount. The health plan, to some degree, although we haven't talked IDR, and those payments can be disputed, but health plan somewhat unaffected until we get into IDR in this case. So again, many different scenarios that can happen, but at least at a base level, here's how some of the reimbursement mechanics work. So I think back to you, David.
No, I thought it would. I thought, Nick, were you taking this slide?
I'm actually going to take it.
Oh, hey, Michelle. Yes, go ahead.
Good afternoon, everybody. My name is Michelle Ray. I'm a senior manager here at Baker Tilly. My background is in health plan and provider operations, largely health plan over the last 25 years, and I'm happy to review some slides with you. This slide focuses on what we identified as sort of the 6 major themes or components of the No Surprise Act that are noteworthy. The first and the second one actually focuses on the independent resolution process. That's a mechanism that's now available to both patients and providers for similar yet different reasons. They're both focused on payments. The first one being the patient and provider dispute process. So this is a mechanism that allows a patient to have a opportunity to dispute a payment that was different from the good faith estimate that was provided by the provider. And we'll go into that process in a coming slide. The second is the provider independent dispute resolution process. And this is the process that the provider has available to dispute with the health plan if they are not satisfied with the allowable amount. And the allowable amount can be determined in a variety of ways. And we'll touch upon that. Good faith estimate. This is actually a new process that is mandated and is available to uninsured or self-pay patients. And basically what it says is that the out-of-network providers must provide the patient with a good faith estimate, which includes the cost or the anticipated cost of services prior to those services being rendered if possible. So certainly if it's, in an emergent setting, that's not applicable. But if it's a scheduled elective service, this is something new. Out-of-network reimbursement rate determination, similar to what Kevin just touched upon. There's a large focus on how those out-of-network reimbursement rates are calculated, what the sources are, and the methodology. Price transparency, that's the underlying theme, I believe, of the whole No Surprise Act from various areas, both from the provider side and on the member side. And lastly, qualifying payment amounts. Again, Kevin just touched upon this. This is a very interesting calculation or methodology that is being applied and will have implications for both payers and providers from just an implementation standpoint. Next slide. So the second slide I'm reviewing is the patient-provider dispute resolution process. Again, this is the process that's a mechanism that's available for a patient to dispute the cost or a bill that they've received for a service for which they received a good faith estimate. So from a high level, a patient gives a provider a call to request appointment or to schedule an appointment, or even to inquire about the cost of services. At that time, the provider has a responsibility to provide the patient or their representative with a good faith estimate cost. And that has to be provided within specific time frames, depending on when the appointment was made, when the request was made. And so it's up to the office at that point to really understand the process and have a process that's implemented. So once the good faith estimate is issued, there are a certain amount of time for which that needs to be forwarded to the member. There again, it depends on when it's requested. If it's requested within 72 hours, there's 1 business day. So there's a variety of different timeframes, but it's important that the provider understands the timeframes and provides the patient with the information. So the service is rendered at this point. Member subsequently, or patient, I should say, receives a bill for a service that's at least $400 the bill. So for example, if the good faith estimate says that the cost of the service was $1,000, but it ends up to be $1,500, and the patient receives a $500 bill, they could be potentially eligible to initiate the patient dispute resolution process. So that would be an example. So the patient has approximately 120 days to initiate the process upon receipt of the bill. And there's a variety of steps that needs to be taken. It includes both submitting information that they've received, and also the provider is required to submit information such as copies of the good faith estimate, um, services that they provided, and then that's submitted to the IDR. And the IDR is an entity that actually evaluates all of the documentation, all of the services. And while this is being done, the patient and the provider can continue to negotiate or come to some kind of resolution. But in the meantime, the IDR is reviewing the information. And just of note, from what I understand, the IDRs are receiving many requests from both providers and members that are not eligible for the process, maybe because the service or the bill was less than $400. So that's something to keep in mind when it comes to the IDR process. And then once it's reviewed, the payment determination must be issued within 30 days. Again, the patient is more than welcome with the provider to come to a resolution prior to that, but the determination is issued within 30 days. Just something to keep in mind, both on this process and the provider side, is there are fees involved. There's an administrative fee to initiate the process. So that's something that as providers and patients think about when they want to initiate an IDR, that there are some costs available. Next slide. This is to highlight some of the major components of the IDR process for providers. So providers have a process or have a mechanism in place to initiate a dispute when they're not happy or satisfied with the rate in which the health plan or the payer paid them for an out-of-network service. So first step, obviously, is that the service was provided. The plan pays a reasonable amount, what they deem to be reasonable, within 30 days, or they deny it within 30 days. We'll be touching on some of the payer requirements a little bit later, but this is an example of a payer requirement that it must be issued within 30 days. So that's something that payers need to keep in mind. Once it's issued, the provider can review and they can implement an open negotiation process. So with the denial or with the payment that's issued within 30 days, there should come with the EOB instructions on how a provider can open negotiations with a health plan and who those health plan contacts are. So the provider can attempt to negotiate with the health plan without going through the IDR process. If that fails, then the provider has an opportunity to initiate the formal IDR process upon 4 days of that expiration date of the open negotiation period. So again, similar to the patient-provider dispute process, it involves submitting documentation, going back and forth with the IDR, requesting information, providing them information. Again, there's a similar process where the IDR needs to make a determination on whether or not the dispute is eligible. And at the end of the day, a determination is made within 30 days. Again, I'm going to reiterate a couple of important notes here. I don't believe it was anticipated the volume of disputes that have been initiated. And as a result, like I said, many of those disputes don't meet the criteria for IDR. So again, something to really keep in mind. Also to keep in mind, again, the cost of initiating an IDR and the administrative costs involved. Thank you.
Great. Thanks, Michelle. All right, so we have polling question number 2. First of all, I want to just share the results from the first polling question around what services are included, and the correct answer was ground ambulance, which was selection D, as in David, and about 30% of you, got that right, leaving a fairly decent chunk, about 70%, that were either not applicable and or one of the other responses. So, certainly identifies an opportunity to continue to, understand this process. And it is a complex process. I mean, we're also getting questions that we're actually, tallying, and we will be responding to the questions, possibly at the end of this, as they're coming in, starting to come in a little fast and furious here. But we are acknowledging that we'll get to some of your questions at the end. But certainly, all the acronyms that Michelle and Kevin and I have already hit. It's a confusing landscape, and so we're going to continue to help you guys sort through that today. So that was the results on the first polling question. The second one is, has your organization experienced? There's another acronym which Michelle's already talked about, the IDR, right? So the independent dispute group, and just looking to get your response over the next 90 seconds or 2 minutes. If you could respond with one of those choices that are in front of you, that would be great. And we'll continue to, persevere with the slides. So next slide, please.
Yep, and this one's mine, David. So I'll just go ahead and introduce myself. I'm Nick Rhodes. I'm a senior manager here at Baker Tilly. Most of my time was actually spent on the provider end, much like David, and I spent a good amount of time in the healthcare space, working for a large organization, provider organization that owns multiple entities, subsidiaries, provider groups, et cetera. And I've joined the healthcare consulting team here at Baker Tilly quite a little while ago, and we've been kind of focusing in on the healthcare sector and more importantly, kind of in the provider space. So, kind of leads me into everyone's probably favorite topic is the oversight and enforcement of the No Surprises Act. So, first couple bullet points here are kind of synonymous, right? So, the responsibility it's a joint responsibility. It's a joint responsibility from the federal and state governments. So you often hear bifurcated process, and you're probably going to hear that a few more times throughout the presentation, to be honest. But as far as the enforcement process varies by state, requires CMS approval. I think that's one piece that is a little vague, or maybe just a little knowledge that not everyone's aware of. So it does require a CMS approval that varies by state. Again, kind of deferring back to that joint responsibility for the feds and the state governments to kind of handle that. The next three bullet points here are really around the federal IDR process, and kind of how the hierarchy kind of falls as far as what supersedes what. So everything kind of falls at this specified state law level. And you're going to probably hear a few more times throughout this slide as well. A few more acronyms. This acronym is SSL, right? And so everything's going to kind of be defined at the state level. And when you look at the state level, there could be this specified state law that indicates here's what the mechanism for payment or what the total payment allowable would actually be, or they may have this all payer model agreement, which we will later talk on a further slide as well. But in each case, the state level, it really starts there. And then kind of trickles its way down to the federal level. So you see it here at the fourth bullet point where it talks about it applies, the federal IDR process applies to states if there's not an SSL that meets federal requirements. So again, just kind of beating in on that point of, it starts at the state, it's defined at the state level, and it can be expanded at the state level as well. We've seen multiple states like New York, for example, and there's numerous others that have expanded the scope of the SSL that not only may take on some of the federal requirements and components of the federal requirements. For example, New York they've taken on the air ambulance piece of the federal IDR process, but they haven't taken on the other pieces. They've actually expanded into other pieces on out of network and providers, et cetera. So it starts at the state and then kind of falls down and defaults at the federal level from an IDR process. So last bullet point here on self-insured plans. The self-insured plans follow the federal IDR process unless they have opted in to follow the SSL. And as some of you may not know, there are 6 states that actually have this opt-in law that's in place. So those 6 states are Georgia, Maine, Nevada, New Jersey, Virginia, and Washington. They're kind of sporadic across the U.S., but they do have opt-in legislation in place. Next slide, please. So the bifurcated process, I think you've heard me kind of touch on it on the last slide. There's 21 states here, and you'll notice, about halfway down, you've got Maryland that has this asterisk next to it. They are the only state that follows this all-payer model agreement, which has indicated that this will be the payment amount across the board for the state. Everything else, or all the rest of the 20 states that are on this list, have followed some other sort of methodology for payments. So, you can see here as far as the cost sharing, it talks in the first bullet point, just on emergency items and non-emergency items, about out of network, in network facilities. So the payments for those other 20 are going to be based on lesser of bill charges or the QPA that's been established in an SSL. Just to go back on the QPA piece just a little bit further, I know Kevin did a great job of outlining that depiction there of what a QPA is and how it's processed and how it's derived and everything else. But just to give you a little bit of an idea as well. So it represents the median contracted rate as of January 31st, 2019 for any given service, and it is increased for inflation. Next slide, please. So I'll touch on the provider side here, and then I'll pass it on to Kevin on the payer side. But this is the operational compliance highlights. I think there's quite a few highlights here that we'll say that have fallen, and we've touched on a few of them already. But just into detail, I think that this is a good kind of checklist to put together on the payer and the provider side, to really make sure that you're kind of following the policies, and then not only that, but putting a toolkit together to succeed down the road. So it's first on the list is inform patients of NSA rights, right? There's a few different methods of communication here. There's verbal, there's written, there's digital. We've seen just about all of those, and another piece of that is getting into the next bullet point is the good faith estimate that we've already kind of touched on as well. Which requires some of those components as well. It has its own checklist. It needs to have NSA rights on it. It needs to have certain language on it. It needs to provide certain data points as far as cost and providers and everything else that needs to be included on those estimates. Adhere to balanced billing regulations, limited to in-network cost share. It's that's a big one as well. Obviously, that's the point of the No Surprises Act, is to make sure and ensure that everyone's kind of following those policies. Another one that's we haven't really talked about so far, but we've talked about the IDR process, is an important phase that starts just before the IDR process, right? And that's the open negotiation process. The open negotiation process is 30 business days in length. And, it starts from the notification from one party to the other party. That notification, once you are notified, the 30 business days starts on that day. And it's important to devise a plan, put a plan together, and make sure that you understand what the next 30 days look like and how you may be able to avoid some administrative costs, throughout the IDR process itself. Another important factor here is revenue reconciliations, right? Processes and assess reimbursement adequacies and calculations. I think that understanding what the QPA is in general and conceptually just, like Kevin was laying it out, is understanding what is derived in that formula to make sure that you're getting paid adequately, and not only that, but making sure that revenue and cash reconciliations are happening, and make sure that you're getting payment on those for what you are billing out, but also what you expected. And then that leads you down to kind of the IDR process itself. I know no one wants a participation trophy in this piece. I know that may be a little bit of a misnomer in some people's eyes as far as participate in the IDR process, but yeah, I do. We put it in there because I think it is an important note to say, once you've put your toolkit together and once you understand what you should be paid and what does a qualified payment amount actually look like in your eyes, make sure that you have a plan together to understand and incorporate the IDR costs, administrative costs, and what that's going to include. I mean, the process itself, the administrative fees have went up starting in the top of the year here in 2023, 600%. So that's putting administrative burden and cost on all the providers across the space.
Yeah.
Develop and implement operational processes to comply with requirements. I mean, I think that goes along with your toolkit, right? Policies and procedures, making sure that you've got enough policies and procedures up front where, from registration to, your business office, your collections folks, everything, make sure that everyone understands what's actually occurring, the payers that are out of network, right? Maybe there's a plan that offers a narrow network and you're excluded out of it. Understanding what that roadmap looks like, and then also implementing internal policies to combat that. Provide patients with access to costs for healthcare services. Goes along the lines of the good faith estimate for uninsured individuals. I would say one thing to kind of note that I probably skipped over is the co-facilities and co-providers. So there was a requirement there for quite a while as far as them trying to roll it out on, including co-providers and co-facilities. And they have now kind of suspended that or pended that for development purposes. They understand that the complexity of this situation between facilities and providers is it's a very complex situation, and it's not easy to transmit that information back and forth. So that was postponed, just highlighting that piece. And I'll pass it off to you, Kevin.
And actually, Kevin, before you jump back in, we're probably up to at least 20 questions, 25 questions, and please attach your name to those questions in case we don't get to them at the end. Okay, so if you could just avoid anonymously submitting, we'd much appreciate it. So we make sure to answer your question. Okay, and then also the last polling question was around the use of the IDR. Less than 1 in 5 of you have actually used the IDR process that we're talking about here today. So it sounds like the majority of you have yet to experience that IDR and get that participation trophy, as Nick was just saying. It's one of those that none of us really want. But I just to acknowledge that it's a significant minority that have used that dispute resolution process that we're talking about here. Go ahead, Kevin. Sorry about that.
No, thank you, David. So quick time check here too. We got less than 20 minutes left. Let's talk a little bit about some of the payer side. We're not going to drain the list. We know most of you on this call are representing providers. But let's talk a little about what happens for the payers. So the payers have the opposite side of most of the items that Nick just talked about. As well, we've got to develop. They have the responsibility of developing certain parts of this, namely the QPA. We're going to talk a little about that in some upcoming slides, because that has some challenges to develop it. And I mean, payers want to make sure that they are compliant with this law as well. I mean, they They want to make sure that they remain in good standing with federal organizations. Many payers have Medicare Advantage and Medicaid business, that they want to make sure that they're staying in good standing. There's some compliance rules about what they need to do, and compliance penalties. We can touch on that, but they've got a lot of tool sets and operational processes to put in place as well. So let's hit the next slide. So let's hit two parts. One is payments. So payments, when the MSA was being created and the guidance started coming out, there was multiple rounds of guidance, and the NSA seemed to suggest at the beginning that it was going to be more prescriptive around provider payments, and yet it didn't become that. And I'll take the third bullet here. It doesn't make a prescription to the amount of the initial payment to a provider. It kind of lets many of the existing mechanisms that are often state by state, based on Department of Insurance rules or based on state regulations. It often lets the states continue to determine what these payments are going to be, what this initial allowance is going to be, and its version of managing payments is in the IDR. Now, so we're seeing mostly the out of the non-contracted payments are relying largely on the way they've always been. Although we're seeing in some cases that the QPAs, are factoring in to the payment amounts, and part of that's due to, especially for smaller payers, they may not have the ability to generate a QPA in addition to an allowance. So there's speculation that some technology constraints come into play. And as well, the QPA is an input to the IDR. So, folks have also believe that, if the QPA, if we believe this is right, maybe this should be form the basis for payments. Although there's been lawsuits about that. And it's not quite figured out yet. There's still, this is still a bit up in the air as to whether or not the QPA is, those get used for payments, or could be how it factors into what the actual payments are. Look at the next slide, please. And then the other side, the QPA. So the qualified payment amount that we've talked about, and maybe just quick reminder, the QPA, the lion's share of the reason for the QPA is in calculating cost share. This is the major driver of why health plans need to calculate the QPA. It also does factor, as I mentioned, number 3, it's an input to the IDR. It can be, in some circumstances, has been used, for provider payments, and it shows up on the advanced DOBs. We're not going to cover that in detail here, but it's important in other areas. It's mainly used in cost share. Next slide. So QPAs, as a provider, or as the QPAs may seem, how did this get generated? And there's a reason for that. Then that is because the calculation of an in-network median. Let me back up. The NSA guidance is over 400 pages long. 80 of those pages dictate how you calculate this QPA, and it's there's a lot of rules. It as well. It strives to calculate this in-network QPA based on the service code, the specialty of the provider, are you in Chicago or are you in Springfield or wherever the metropolitan area that you're in, or a non-MSA. What service category is this? Anesthesiology? Is it outpatient, inpatient? Office visits? And then it says also calculate these by insurance market, because we know often retail prices are different than group prices. Well, that's a lot of factors. Then that leads to potentially a lot of QPAs. So as well, the legislation says you need to have at least 3 rates. Well, when you're slicing and dicing by so many different dimensions, you often run into a case where you don't have 3 rates. And then there's sufficiency rules that come into play, etc. Let's hit the next slide for a sec, if we may. It's a polling question. Let's hit this, and then I'll segue into the next one.
Yeah. You know, how often do your NSA qualifying claims use QPA as a basis for payment beyond for the member share, right? So you can see the responses on your screen, and we'll allow Kevin to keep the momentum going. But this is our 3rd out of 4 polling questions, and we'll be back to you with those results when we get to the 4th polling question in the next 5 to 7 minutes. Keep going, Kevin.
So we've talked about a few of these challenges for payers. The calculation is complicated. There's a multi-layered kind of weaving together of rates and construction of these rates that, you know, has been challenging for payers and third-party administrators, especially for smaller health plans, mid-sized health plans. And there's some maintenance required. You need to make sure that you're supplying how you calculated them. They need to be updated for inflation each year. There's new codes that come out, and there's specific rules around how to calculate QPAs for new codes. As well, if you didn't have enough information in the first round of QPA calculation, now you know there's a whole section on how to calculate those now that you do have sufficient information. So long story short, QPAs, you know, are not easy to generate. So let's move on. We wanted to highlight an example of why they're complicated. You know, in the interest of time, we won't spend too long on this, but when we talk about rates, oftentimes rates they're not fixed rates, right? Many providers on this call, many payers on this call are paying based on different methods, right? There can be percent of charge based payments. Medicare schedules are being used, fee for code. There can be lesser ofs. There can be all sorts of different payment mechanics that make calculating a median of a rate that is a little hard to pin down challenging. So lots of challenges. Next slide, please. Nick, you want to talk about some provider challenges?
Yeah, I mean, I'd love to. So some of the challenges for provider. What's that, Dave?
You'd love to? That's strong. That's
Yeah.
strong.
Yeah.
Go ahead.
I know we do have kind of a time check here, but I'm going to try to get through some of these challenges and then definitely try to get, you know, through the opportunities as well on the other end. But so some of the challenges here, you've got the advanced EOB, which Kevin had just kind of alluded to. It's been postponed just due to the fact that I don't think development of that has occurred as fast as they wanted. And it's also, I think it's very complex, right? The complexity of the situation is very high, and they're trying to understand it's going to cross from the patient, right, coming into the provider that's going to submit it to the payer and then back to the patient, right? So the feedback loop gets kind of long and it's arduous. So they're trying to figure out how to get that back around electronically, and the development of that is still in the works. You know, moving on to the next one, we've kind of talked about it as costs, right? The cost of the IDR process went up 600% from an admin standpoint in 2023. So really choosing when to take it to the IDR process, especially knowing there's been such a delay and backlog in the IDR, that you really have to formulate a plan on how strategically you move forward with what claims, et cetera. Next is methodology and calculations used to determine the specific QPAs. As Kevin's kind of broken it down for us, you know, the last slide is a great visual on how complex these are, and you know, not just on the payer side, but the providers trying to understand these and the formulas behind them. So I would say that understanding the methodologies and using remittance codes and remark codes that are provided to understand how the payer is adjudicating these claims. Administrative burden. So you've got time and cost involved with these, running through the IDR, running through open negotiation. There's an opportunity cost with that, avoiding when you can. And I think that's a great segue into the next one, which is establishing relationships with key payer network management staff, and not only that, but just finding where the gaps are. Right. I think we would love to be able to put paper and contracts in place with every payer and avoid all of the out of network issues and have a great rate, right? Great reimbursement rates, but it's not feasible. And so understanding what that landscape looks like to be able to identify the gaps and close those. Reconcile reimbursement and calculation methodology. It kind of goes along with the calculations and just determining how they're paying, whether it's an all-payer model agreement, whether it's an SSL, whether it's, it defers to kind of the federal processes as far as IDR goes. Understanding each state is important, and contiguous states. Understanding, where your patient population or referrals are coming from. You can, next slide, please. So opportunities, on the provider and the payer side of things. So if you're looking at the pie chart here on the left-hand side, that's provider-focused opportunities. And I think one of the biggest one, right, is going to be your bottom left there, where it's increased cash flow through point of service collections and bad debt reduction. So being able to collect upfront, whether that's through prompt payment discounts or putting some sort of sliding scale in place and making sure that we're providing discounts, getting collections up front, making sure you have a good process from a registration standpoint and even a scheduling standpoint to make sure that you're collecting as much as possible up front and avoiding bad debt collections, sending multiple statements. Every statement you send has a cost associated with it. So every day that it sits in AR, it's there's cash flow issues. So I think understanding what that is and collecting up front is definitely an opportunity, especially with the good faith estimates, right? So if you already know what's due and you have a good mechanism to be able to provide that estimate, then you should know right off the bat what that patient responsibility is going to be. Understanding the benefits and also articulating that to the patient, which also provides patient satisfaction. Decrease and lessen administrative burden to remain out of network, right? So work with the payers, work with these out of network payers, whether it's through different states or wherever that may be, right? Work on trying to clean it up, get paper in place, and make sure that you're increasing the amount of in-network patients that are coming to your facility. Contract with additional payers and increase payer mix kind of goes along with the other bullet point. Those are inextricably linked there. Drive additional volume through network referrals, and that's kind of the third piece of the pie that's inextricably linked as well. The more patients you can get in network and get in that tier one, right, and drive to your facility, et cetera, it's key, and especially increasing or reducing, we'll say, the administrative burden that you have to be put on place as far as these out of networks, the IDR, et cetera. Forecast reimbursement through network fee schedules. I think the QPAs it's a median, right? It's not what you would be paid if you were in network. So being able to forecast some of the reimbursement and understand what those network fee schedules are and how those are changed year over year and what those percentages look like, I think is important to understand what the net revenue looks like impact wise from payer to payer. And I'll pass it on to you, Kevin.
Sure. Let's just, in the interest of time, I think the major opportunities for payers are the top two quadrants here on the right hand circle. I mean, there's opportunities to expand your network, and that's generally good from a network adequacy perspective. It's generally good for product construction. So there's opportunities to get out of non-contracted providers, into the appropriate network health plan networks, and then also it improves member and thereby large employer groups. It improves satisfaction. the elimination of surprise bills, the elimination of different payment scenarios to avoid members getting impacted is generally good. Certainly we need to figure out, payments and how all of that works, but there's some benefits here.
Yep. Great. So a couple of housekeeping items. We're at 2 minutes, to the top of the hour, and here's our last polling question. So please respond while I kind of land the plane here at the end of the hour. What aspects of NSA compliance is your organization struggling with? Certainly we hope over the last hour or so we haven't overwhelmed you, but instead have provided some insights to help you kind of break this process down and start to understand some of the benefits of it. You certainly probably already understand some of the challenges of it, which we outlined. And then really importantly, over the last 5 to 7 minutes, Nick and Kevin have identified some opportunities on both the payer and the provider side, to have this be a positive experience for both sides. And even more importantly, the member and the patient are going to benefit, from this act in the long run. And we should all remind ourselves of that when we get frustrated with the process. That's our fourth polling question. The third polling question, the results were, around the frequency of QPA and its applicability to payments. Over half the group wasn't sure. So that indicates that there's still a lot of opportunity to educate both the payers and the providers on this process. We are going to continue to pump out thought leadership on this topic for sure, because we think it's super important. We are also going to reach out to those folks that assigned their name to their question and try to get to those questions. I think we probably approached over 20 questions, maybe even 30 questions. We simply don't have time to respond to those right now. There's a lot of technical questions. And if you didn't assign your name, if you want to resubmit before we stop this webinar, resubmit with your name, we'll reach out. If I could also ask the event coordinator to put up our contact information, up on the last slide. If you want to jot down any of our emails or phone numbers, you can reach out directly to us with the answers to your questions. Questions like, how do you calculate the good faith estimate? Is there a fee for the dispute resolution process? Does this apply to skilled nursing facilities? And all the questions that came through. We will be darn sure to respond to all those that where we have an identity attached to the question for sure. So we appreciate, first of all, appreciate the panelists, Nick, Michelle, Kevin. Thank you very much for your insights. This is obviously a regulation that takes more than an hour to fully dig into. We are going to probably go into a series of these webinars on this topic because it's so kind of central, to the payer provider operations. We at Baker Tilly, embrace both sides of the equation. And I think hopefully that came across today, that we understand both sides in a meaningful and deep way, and would love to be able to help you guys out, not only in answering your questions, but as you kind of go through and refine your processes. The final results are somewhat mixed on the last polling question, but only about 9% of you said that there's nothing you're struggling with. So God bless those 9%. And then there's a 9% on the IDR and 10% on the QPA, and 8% on calculating the QPA, 7% on the advanced EOBs, et cetera, right? So certainly there's struggles all around out there in the marketplace. Hopefully today's webinar helped give you some additional insights. We appreciate your time today. I know we're over by a couple of minutes. Again, we're going to try to get to your questions as long as we know who asked those questions. And again, I thank the panelists and look for our thought leadership going forward. You have our contact information on the screen here. And so I will sign off. It's probably halftime of the first round of games on March Madness. Again, good luck on your brackets. Good luck with NSA. And enjoy the beginning of spring and St. Patrick's Day. Take care, everybody.